So, as Elaine mentioned, I'm going to be talking to you today about tailored messaging as a mechanism to improve uptake of recommended health behaviors. So I just want to disclose some conflicts of interest. I serve on advisory boards for Pfizer and Merck, but neither of these companies fund any of my research and have no role in any of my research. So here's what we're going to talk about today. We'll start off with just a brief background about what is tailored messaging, because I imagine there's several people in the room that might not be that familiar with it. And then I'll go through a little bit on the evidence of the effectiveness of this approach. And then we'll really dive into the nitty-gritty of how do tailored message interventions work, how do you do these types of things if you're interested in pursuing this. And then I'll go through some examples of some tailored message interventions, both from my own work and from that of others. And then for the last few minutes of the talk, we'll talk about some implementation and dissemination issues that are sort of ongoing issues still to be resolved. So let's dive right in and talk about what is tailored messaging. So as I was putting this talk together, it struck me that tailored messaging is essentially a way of trying to make it seem as though you're having a conversation with some type of electronic device. So it could be a computer, it could be your text message system, it could be emailing system, whatever. But really what tailored messaging does is tries to, as much as possible, simulate an interaction with a real live human being, although it's certainly not meant to take the place of person-to-person interaction. So tailoring, the word tailoring refers to any number of different methods for creating communications that are individualized for the receiver. And the key word here is individualized. So this is a technique that provides information that's uniquely personalized to each individual. Tailoring actually exists along a continuum. So down here, let's see the arrow. So down here at the bottom, just to orient you to this slide, this is the degree of customization from low to high and degree of audience segmentation from low to high. So most materials that we use in trying to promote health behavior change are general or mass audience types of materials that have low degrees of customization and low degrees of audience segmentation, which makes sense because these are general mass audience types of information. The next level up is something we call group targeted materials. So this is where you might specify information based on a broad subset of the population. So for example, African Americans or parents or women. What I'm going to be talking about today is something that exists at the upper right-hand corner of the spectrum, which has a high degree of audience segmentation and therefore a high level of individual customization, so individual level tailoring. Before we get too much further into what is tailoring, I want to just spend one slide talking about the difference between tailoring versus targeting, because these terms often get used interchangeably, but they are not the same thing, and people tend to misuse them. So targeted information, as we saw on the previous slide, refers to providing information to specific subpopulations, whereas tailoring refers to providing information that's specific to individuals. So here's a couple of examples showing how you might do one versus the other. So a targeted message might be something like, infants are at highest risk of dying from pertussis, whereas a tailored version of that message might be something like, Judy, that would be the mom's name. Did you know that a 6-month-old infant like Jeremy are 10 times more likely to die of pertussis than any other age group? So here you can see we've got tailoring based on the mom and the child's name, based on the child's age, and then we provide a very specific risk estimate, 10 times more likely, that's linked to that child's age. Now, I don't know if pertussis is actually 10 times more likely to cause death in infants that age. I just made this up for the example, but that gives you a sense of kind of how we might use tailored messaging and how it's different than targeted messaging. So tailoring has essentially two goals. The first is to influence the way that information is processed and to make it to make people more engaged with how the information is coming in. So to do this, the goals of tailoring are to grab people's attention, and this often occurs by creating some type of emotional response to the information that's being provided. So a good example of this would be when somebody uses a vignette, personalized vignette, where someone's telling an emotional story that can create an emotional response and tends to grab your attention. And what this does is it helps to better engage the internal processing of that information so that you're more recognizing and aware of it. You also, by doing this, you're able to enhance the message's impact. So what you want to do is target specific theory-based constructs. So some of the theories that are often used in this would be like the health belief model or the theory of reasoned action. And you want to try to engage theory-based constructs that are known to either mediate behavioral intention or the actual behavior itself. So some examples of that would be things like self-efficacy for performing the behavior, attitudes, which might serve as a barrier to doing that behavior, or normative perceptions. What are most other people doing related to that behavior? So when you tailor, it helps individuals to perceive materials as being more personally relevant to them. And by doing so, you can enhance their motivation to act on that information and also increase their sensitivity to the arguments that are being provided. So in some ways, you're priming the pump. So you might give the same information to many people, but if you're able to tailor it, that information is more likely to be intrinsically processed and acted upon. And that increases the persuasiveness of the information. And these are concepts that come from the elaboration likelihood model, which is another model that's often used in tailored interventions. Another reason to use tailoring is that you can actually simultaneously address multiple levels of factors that might influence the health behavior that you're interested in. So this is peeling back the onion, as you might say. You have lots of different things that are known from prior studies to influence health behaviors, things like demographics here on the outside, physical, mental, functional health, your problem-solving approach. So do you tend to like more emotional-based information, or do you like fact-based information? Your patient orientation, so are you more visually oriented? Are you more numerically oriented? You can take advantage of things in the clinic-patient interaction, stages of change. So are you in the pre-contemplative phase, in which case you might give different information than if you're in the ready-to-act stage of change. There may be some components of your social support system where you can draw on other people's experiences and tailor on those types of information to improve the personalization of the materials, barriers, and then self-efficacy. And this is just a partial list. There's obviously other things that you could think about being layers of this onion. So tailoring has essentially three components. The first is called personalization. And sorry, I just didn't want to bang my leg out there. So personalization can take many forms. The first one, the most simplest, is to actually use the person's name. So you might say something like, Jen, it seems like you are worried about vaccine side effects. A second way to do this is to point out that the information is actually customized by saying things like, based on the information you provided or based on your survey questions, it sounds like one of your main motivations for quitting smoking is to make your family safer. And then the third way to personalize information is through contextualization. So this can be in the form of pictures, where you have pictures that are matched to a particular situation or a particular person's demographic characteristics. Or you can do contextualization in terms of geography. So an example of that might be something like, since you live in Denver, you might want to try the YMCA in Stapleton for exercise classes in your area. The second component of tailoring is what's called feedback. And there are two types of feedback. The first is descriptive, where you basically are reiterating to the person that you, quote, heard what they said. So you might say things like, you told us, or you indicated that you don't think your asthma is under good control. That's trying to make the person feel like the intervention is understanding them. There's also comparative feedback, where you give a piece of information in reference to another time point. So an example of that would be, you're eating 2 more servings of fruits and vegetables than when you first enrolled in our program. Or another example might be, your son weighs more than 95% of other children his age. The third component of tailoring, and this is really the main component, is something called content matching. And that's where you have some kind of systematic way to assess what are the most important issues for that person related to that health behavior, and then produce messages that are really specific to those particular topics. And what this does is it minimizes the process of searching for information. So most mass audience types of educational materials, often people will have to kind of skim through to be able to find the stuff that's relevant to them. Tailored messages, on the other hand, present the most relevant information up front, so you can actually provide information potentially in a much more efficient manner. So let's turn our attention now to some evidence on effectiveness. Tailored messaging materials have been around for quite a while, at least 3 or 4 decades, and in 2007, Seth Noor's group produced a meta-analysis that reviewed tailored print-based behavior change interventions. And this meta-analysis included 57 studies. What they found in general was that untailored information is not as good as tailored information in most cases, but the effect sizes are small to moderate, so the R values are between 0.05 and 0.2. In many instances, it seems like print-tailored materials have a better or greater impact on females compared to males, but in this meta-analysis, they didn't find any differences in the impact of these materials based on other demographic factors such as race, age, or education. There also appears to be a dose effect. So the more times somebody interacted with their tailored intervention, the more likely they were to follow through on the desired health behavior. And there was also an effect in terms of the number of tailoring variables that were included. So more seems to be better. If you tailor on more things versus less things, you have a better effect. And we'll talk a little bit later more about sort of the issues around the depth of tailoring. They also look at this meta-analysis in terms of the output format. And so they found that in general, tailored pamphlets were more effective than tailored or personalized letters. And both of those were better than sort of the longer-term formats such as manuals or booklets. And some of the specific types of health interventions that were included in these studies were things like pap testing, smoking cessation, mammography, adherence to diet and exercise. And so I just put that in there to point out that tailored messaging has been successfully used both for sort of intermittent preventive type health behaviors as well as for management of chronic diseases such as asthma, diabetes, obesity, etc. This is a figure from that paper, and just to orient you here, the orange line is sort of neutral effect. This side is favoring untailored materials, and this side is favoring tailored materials. And you can see pretty much across the board the effect sizes from all of the studies fall into the favored tailoring side of the graph. Now, in 2013, the same group actually came out with a meta-analysis of tailored interventions that were web-based. And this was quite a bit more difficult to analyze because web-based intervention, as you can imagine, has a lot more potential moving pieces to it. You can tailor on a lot more things because it's more automated, and you can also include other things in your web site other than just text. So you can include movies or audio or other types of videos. So this meta-analysis included 40 studies, and it showed, again, that tailored websites were better than untailored websites, as well as better than a usual care arm, which was usually no website and some other type of information. And as I mentioned, many of the websites included other communication tools, so that makes the comparison a little bit more difficult. One of the interesting things they found was that there was no waning of the impact of these interventions over time. So some of these web-based analyses actually included a longitudinal assessment up to about 6 months after the initial intervention to look at the impact on health behavior at that later time point. And they found that there was similar effect size both immediately after the intervention was given as well as in the longer-term follow-up. There was also no significant difference between whether or not the intervention targeted a single health behavior, so for example, stopping smoking, versus multiple health behaviors such as cholesterol management through diet, exercise, and lipid-lowering drugs. They found that the materials were more effective when targeted to the general public than to a specific population. And overall, the effect sizes, if you look at the studies averaged altogether, were larger than that seen based on print materials, which kind of makes sense because you can do more sophisticated tailoring with a web-based intervention rather than a print-based one, which is static once it gets printed out. So here's that similar graph. Again, to the left of the orange line is favoring the control setting. To the right is favoring the tailoring. And you see that there's a bit more scattering along here. Some are actually falling into favors comparison, but the effect sizes of some of the ones in the tailoring size are actually quite large. So the R values here, some of them are up to 0.8, which is a pretty significant effect size for intervention. And I don't know offhand what exactly that study was about, but it is in this meta-analysis if anyone's interested in looking that up further. So I wanted to go through some data on a particular example. This is something I pulled from the University of Michigan's website. They're one of the groups in the country that do a lot of tailored messaging interventions. So this is not a project that I was directly involved with. This project is called Click to Quit, and it's a smoking cessation program. This is what the main landing page or homepage looks like. And in this study, they evaluated a tailored version of Click to Quit versus an untailored version of Click to Quit. And their main outcome was abstinence from smoking, 10 weeks of continuous abstinence that was assessed at a 12-week follow-up. So you can see that in the intent to treat group, tailored messaging had a superior effect to untailored messaging, so about 4 to 5% more people were significantly abstinent in the tailored versus untailored group. And the effect size was even larger when you look at the protocol group. So for those of you who might not be able to see in the back, it's 55% abstinence versus 43% abstinence. They also did some interesting subgroup analyses. So this is, to orient you here, this is percent abstinent on the y-axis here and whether or not the person had a tobacco-related illness. So for example, COPD. So the population was divided into people who did or did not have a tobacco-related illness. And the light blue is the tailored intervention. The dark blue is the untailored or control intervention. And you can see that in both groups of people, tailored messaging was superior to untailored, but the effect size was much larger in people who had tobacco-related illnesses. And similarly, when the population in the study was subdivided by those who had frequent alcohol consumption, which they define in this study as those drinking 3 or more times a week, you can see that the effect size was magnified. So this could potentially point to other types of tailoring variables that future iterations of this type of intervention might want to consider. So now I'd like to turn our attention looking at what are the actual mechanisms of how tailored interventions work. Essentially, there are 3 main steps. You take some data that you assess in a very systematic way. You apply a set of rules to this data, which are things like logic algorithms. And from this, you generate some type of output that is your tailored intervention. So what this means in reality is that you perform a baseline survey. This is how most tailored interventions actually start. And in this baseline survey, you want to assess tailoring variables. We'll talk a little bit more about what those might be, but these are things that you want to tailor your information on. So things like demographics or beliefs would be some examples. The next thing you do is you access what's called a tailoring engine, and I'll show you that in a moment. That tailoring engine goes back and looks at the data that's been put into the baseline survey and uses the engine to create content for your intervention from what's called a message library. I'll show you what that is in a minute too. And from this, you end up generating your tailored content, which the person then views, and then hopefully at some point in this process, you are evaluating the impact of looking at that tailored content. So here are some examples of some tailoring variables that you might want to consider. This is by no means meant to be an exhaustive list. We talked about some of these already. One thing that's interesting to think about is goals or health values as a tailoring variable. So this can be very powerful because it tends to elicit an emotional response. So an example of this might be something like, you told us one of the main reasons you want to lose weight is so that you can keep up with your kids when they're playing. So that's an example of a tailored message that's related to a specific person's goals. You can also do things like test results. So, for example, your hemoglobin A1C is 10.2. It looks like we need to get you under better control. And then geographic norms and stages of change, as we talked about earlier. So the message library is essentially the key that ties the tailoring variables to the content that you're generating. So to me, the easiest way to think about this is if you're using barriers as one of your tailoring variables. So if a person scores high on barrier 1, they get message 1, linked to that barrier. Or if they score high on barrier 2, they get message 2. And likewise for barrier 3, they get message 3. So here's some specific examples about from the message library for a study that I'm going to show you more about a little bit later, related to human papillomavirus vaccination, also called HPV vaccination for adolescents. So an example of how we link the survey to the message library is shown here. So in the survey, one of the barriers we assess is HPV vaccines are not safe, and parents could agree or disagree with that statement. So if they agreed strongly enough with it, they got something from the message library, a paragraph that was titled Vaccines and Short-Term Health Effects. Similarly, if they scored high on the barrier that giving their daughter the HPV vaccine would encourage them to have sex, they get from the message library a paragraph called Giving the Wrong Message About Sex. And if they've scored high on the barrier that their daughter is too young for a vaccine against an STD, then they would get the paragraph titled "Too Young for the Vaccine" and additional information provided there. And you'll see some examples of this later on. So you might be wondering, well, what is a tailoring engine? The tailoring engine is really the key to this entire process. You can't really do this unless you have some type of tailoring engine that you've either written yourself or have accessed. And so as I came from the University of Michigan, I'm familiar only with the Michigan tailoring system. There may be others out there, but I don't know of any that there are. But the Michigan tailoring system is a very powerful tool. And this is a screenshot from their homepage. So you can actually Google Michigan Tailoring System and find this information. And what you see here is there's several components. There is a Learn MTS, that stands for Michigan Tailoring System. So this is a series of webinars with associated PowerPoint slides that you can look through. There's about 10 of them. There's also another series of lectures and PowerPoint slides about tailoring. So many of the slides, well, not many, but some of the slides that I took for my presentation, I actually downloaded from their website. You can also get the MTS program. It's free, readily available, and works on a lot of different computer systems. And then they have a Get Involved site, which is a thing like a listserv and a chat room if you have particular questions. So you may be wondering, well, what do you actually have to do if you're using the tailoring system? So I'm going to show you this kind of macro view, and then we'll scroll in and look at this more closely so that you can read it. This is what it looks like when you're in the MTS system. There's a menu on the left of all the things that you want to do. And on the right-hand side, in this bigger box here, this is where you're writing your code. So this goes on and on and on and on for pages and pages and pages. So here's a close-up of some of that code, and this is just a really simple example to show you how you would actually write part of a tailored messaging program. So you see over here we have something called heading, and the heading is our HPV vaccine safe. And now we have something that says block. This means we're doing a block of text that's going to be tailored. So we're going to select either text 1 or text 2. Text 1 would be applied under this logic. We have a barrier called health problems and a barrier called unsafe that we're assessing in our baseline survey. So this logic says that if either one of those is scored greater than 5 on our 10-point scale, then they get this sentence. It sounds like you're really worried about the HPV vaccine causing your daughter, and we insert her name, we can tell that because it's in blue, health problems in the future. Whereas if they had a score of less than or equal to 5 on either a barrier of health problems or barrier of unsafe, then they would get a slightly different sentence that says many mothers worry about the HPV vaccine causing health problems for their daughter in the future. So this is a very straightforward and simple example. You can get much more sophisticated and detailed with how you do the tailoring using this program. So this brings us to sort of the issue of depth of tailoring. There's a whole range of tailoring depth that can be utilized, from light tailoring, which is an example I kind of showed you, block tailoring, where you tailor on a paragraph level, all the way to deep tailoring, which is also called micro-tailoring, where you can tailor each individual sentence or even parts of a sentence tailored to specific tailoring variables. And then in between is moderate, where you might have mostly paragraph tailoring and some individual sentences being tailored. And this is often depicted in these diagrams here on the right. So here you see big blocks of colors and not too many boxes, whereas here you see lots of different colors and the boxes are more small. So I wanted to show you an example of a high versus low tailored example, and I'll just read this to you because it might be hard to see in the back. So the low tailoring example says this: once you quit smoking, you feel that you might be tempted to light up when you are stressed. Managing stress is a valuable skill to have. We want to help you make sure that cigarettes are no longer a stress solution you want to reach for. This section of the program provides valuable resources and healthy ways to help you cope with a variety of things life may throw at you. Now contrast that to the high tailoring example. When you rated the triggers that might tempt you to light up once you quit, stress was at the top of your list. You also told us that you have a lot of stress in your life right now and that you don't always cope well with it. Based on this, you may want to spend a little extra time in this section of your program that highlights the many ways to manage stress that fit well with both your work and your family life. So you can see there's a real difference there, and one is a lot more personalized. Another way to sort of show how this works is a picture of it. So this is an example of low-depth tailoring. It doesn't really matter what this says. All you have to really focus on is what's over here, the tailoring variables that are being used. So you see in this instance, there's one instance of name tailoring. There's 2 instances of gender tailoring. So sentence and the picture is a man. This is a male-focused intervention. And then one piece of a sentence related to stage of change. But the rest of this is actually going to be the same for everybody, not tailored. You can compare this with a high-depth tailored similar web page where you see, in addition to name, gender, and stages of change, you also have age, ethnicity, marital status, smoking status of the spouse, child in the home, whether or not they're physically active, the number of cigarettes that are being smoked, specific attitudinal barrier, their job status, and their social support. So you can see that there's a lot of different ways to do this. Image tailoring also matters, and I pulled this from the University of Michigan's website too, because I thought it was a pretty cool experiment. So they did an experiment where they looked at how well people visually interacted with materials where there was either a picture that was matched based on race and gender, mismatched based on race and gender, or just some random picture. So these are a happy couple walking off into the sunset. And they use this pretty cool device called a Tobii 2 eye tracker. Has anybody ever seen this before? They kind of look like Google glasses. So this is actually a way to measure where your eye looks on a computer screen, and I'm not entirely sure how this works, but I believe there's like a grid placed in the lenses of these glasses that can measure where your eye is tracking, and then this is linked to a similarly gridded computer screen, and so you can actually see where on the screen people's eyes are looking at and for how long, and you can actually quantify their visual tracking in terms of where or length of time they're focusing. So I hope that you can see this in the back. I'm not sure what the difference is between blue and yellow here, but they're both tracking your eyes in some way. And what you see is that in this matched image, people are looking at the sky a lot. They spend a lot of time on this one eyebrow here. They're looking at his eye. It looks like they looked at his chest hair a little bit, the V in his collar, and then they're looking quite a bit through the text. Compare that to the mismatched image where you'll see that they're looking at significantly less at her face and about the same amount, I guess, at the text here. And then if we compare that to the random picture, you see that they took like one or two brief looks at this couple walking in the sunset and not looked at them at all. So I think this is an interesting way to sort of talk about how powerful images can be and how they can help you deliver your message in a way that is perhaps more meaningful to people. As I mentioned, outputs of tailored messaging can take lots of different formats, paper-based and web-based. We've talked about in those meta-analyses. Text messages you can also do. I'm not entirely sure if the MTS program does text messaging, but I know that the University of Michigan has done a lot of tailored text messaging programs, so they would be the person to ask about that. You have to be really creative in a text message about how you're going to tailor it in just a few little sentences. You can tailor based on testimonials, so these are like video vignettes. You can tailor with interactive tools such as a decision aid that might be pre-populated with information that's derived from the baseline survey. And although I've not personally seen this, it seems feasible to have tailoring of an audio type or video type if you've had a large enough budget where you could make enough types of materials that are able to segment your audience into small enough parcels. You could imagine an audio or video-based tailored intervention. So now let's turn our attention to some examples of tailored messaging interventions. And I'm going to start with two vaccine-related interventions that come from my own work. They have very similar names. One is called VaxFax-HPV, that stands for Human Papillomavirus Vaccine, and the other is VaxFax-MMR, which stands for the Measles, Mumps, Rubella Vaccine. So VaxFax-HPV was a small pilot study. It was a randomized controlled trial. And the intervention group ended up receiving a 2-page individually tailored printed brochure, whereas the control group received the vaccine information sheet that's pictured here. So these vaccine information sheets are produced by the Centers for Disease Control and Prevention, and they're actually required by law to be given to people prior to giving them a dose of vaccine. And these vaccine information sheets are meant to contain general information about the disease and the vaccine that's meant to address people's questions and potentially concerns about this. Although these are really variably used in the clinical setting and oftentimes are given after the dose of the vaccine is given, but that's what we have as our standard of care. So the study sample consisted of mothers of adolescent girls who were ages 11 to 17 years old, and these mothers had some type of concern about getting their daughter vaccinated against HPV. So this study was done only a couple years after the HPV vaccine became available. To qualify for the study, the daughter could not have received any HPV vaccine doses. So these are moms making the HPV vaccination decision for the first time. And we recruited our sample from primary care pediatric clinics. Our main outcome that we looked at was change in vaccination intention, comparing before they looked at the educational materials to after. We unfortunately weren't able to measure actual vaccine uptake in our study because of our limited scope and budget, but that's certainly an important outcome that needs to be considered. However, if you look at some of the health behavior models, vaccination intention is recognized as a reasonable upstream proxy measure for vaccine delivery. So, as with all of these tailored interventions, we started with a baseline survey. And the survey covered 21 items that were known to be potential barriers to HPV vaccination that we derived from the literature. And then we looked at a few different demographic variables and 4 key variables related to past history that we thought might be influential on HPV vaccine acceptability. So this included things like ever refusing a vaccine that was recommended for their children before, and whether the mom or anyone close to the mom had ever experienced an abnormal pap smear, genital warts, or cervical cancer. So the way that this particular intervention worked is we had the tailoring engine select the top 3 barriers from the message library and create our content based on those 3 barriers. And then we also had a little bit of more detailed tailoring based on race, which was a matched picture, and then some sentence tailoring that included past vaccination behavior, past HPV history, number of children, and then throughout the text we incorporated the daughter's first name. So here's some comparative examples of 2 brochures from the VaxFax HPV study that a mom might get depending on how she answered the baseline survey. So the first thing to notice is that there's different pictures. The mom on the left identified herself as Caucasian, whereas the mom on the right identified herself as African American. There's also different things that are listed as the top barrier. So the mom on the left must have said that she was worried her daughter was too young for a vaccine against an STD because she got the too young for the vaccine paragraph from the message library, whereas the mom on the right had concerns about HPV vaccine effectiveness. And then throughout the text, I know you can't read this in the back, but you can just see how frequently we use the child's first name. So on the left it says, you told us you think Olivia is too young to receive an HPV vaccine since it prevents a sexually transmitted disease. And on the right it says, however, getting Jennifer vaccinated will reduce her risk of cervical cancer by 70%. So what we found in this study is that there was significantly more positive change in vaccination intention among the intervention group when compared to the control group. And not only that, but the people who received the tailored intervention actually had attitudes that shifted from negative to positive as opposed to negative to neutral. So this is depicted below here. You can see our control and our intervention group, and this is our 10-point scale that we use to assess vaccine acceptability. Both groups started out as an average of 4, which is below neutral. Neutral would be 5, so that's slightly negative attitudes about the vaccine. And in the control group, this raised to just above 5, whereas in the intervention group, it raised almost to 6, so more squarely in the positive vaccination intention. So it seems like in this study, we were really able to get parents over that tipping point and potentially put them into the positive attitude category. This is a similarly designed study, but the output is different. So instead of having a 2-page printed brochure, we actually had a series of web pages. And this is similarly a pilot study focused on parents who had younger children and had concerns about the MMR vaccine. And they received, after their baseline survey, they received their information either tailored or untailored. So in this case, the untailored information was just the vaccine information sheet data that was put into a web-based format, whereas the tailored information is shown here. So you can see across the top, here's your baseline survey, your tailored information, and then here's where we do our assessment after the information is viewed. And there's a number of topics that are listed here on the right, and then I've color-coded this so you can see more easily how it's been tailored. So here again, we have an image tailored. This is an Asian American mom with a female child. We have the child's name given throughout. So here it says, you're worried giving Jane the vaccine could cause her to develop autism, or choosing to get Jane vaccinated can be scary. This is a sort of a normative tailoring here. It says you've heard from friends, family, or the news that make you concerned about the safety of the MMR vaccine. And then this entire paragraph in blue is actually reflective of tailoring. it says from your answers, it sounds like you're worried that the vaccine isn't safe, there's more risks than benefits, might cause autism, has side effects, hasn't been around long enough, and children are getting too many vaccines. So all of these things listed here are barriers that this particular mother actually indicated she had. And then each of these is live links to additional information on that topic. So, as I mentioned, both of these studies examined the impact of the materials on vaccination intention, and both showed that the tailored materials were superior to the untailored materials in improving this outcome. And we have a much larger ongoing study right now to look at this type of intervention for its impact on actual vaccine utilization. So I'm hoping to have that data in about another year. Here's a couple of other examples. This is an example of a project I was not involved in, but it's another smoking cessation one. And I picked this one because you can see here that it has actually 6 sessions built into it. These are listed across the top. And then it has special feature, and then this is actually a smoking cessation project that's used in conjunction with nicotine patches. So it has some information about that. And all the information in the actual paragraph here is tailored. And then this one was my favorite one. So I don't know if any of you have been on the University of Colorado's My Health Media website. Has anybody participated in that? Yeah. So the folks at University of Michigan actually developed the company Health Media because there was such a demand for this type of information. So they actually have a spin-off for-profit company that isn't involved in any of my research, and I have no association with that company, so I don't want you to think I'm advertising them. But they actually have found that there's such a demand for this type of intervention and information that they developed My Health Media, which does things like promote health and wellness to large organizations such as the University of Colorado. And so all of us have probably received multiple emails about this program where we go in and we fill out a big health assessment and ask about our eating habits, our sleeping habits, whether or not we smoke, how much we drink, what our diet's like, exercise. And then this is actually a screenshot from my homepage showing kind of what it looks like. So we've got coaching sessions here. They can help me with my stress or my time management problems. I can track my progress. I can try a tool. And my favorite thing about this, I didn't notice when I first actually went on this website, is I'm imagining that the picture is tailored, and if you'll notice, our hairstyles are very similar. So although I don't ever wear pearls, I thought they did a pretty good job in matching the images there. So I thought that was good. Okay, so for the last couple minutes, I just want to talk about a few key dissemination and implementation issues that are still, I think, unresolved issues in the field of tailored messaging. And there are 3 of them. The first one is how much tailoring is enough, because more tailoring is more labor intensive and therefore likely to cost more. Then there's issues about reach versus depth, and I'll give you some concrete examples of what I mean there. And then sort of this, I almost want to say like ethical issue that I'm personally struggling with, which is effectiveness versus usefulness. And I'll tell you a little bit more about what I mean in a second. So let's get back to the first question. How much tailoring is enough? So this is, again, another study that was taken from the University of Michigan's website. And it's, again, a smoking cessation study. And what you can see here on the y-axis is the percent of people who were abstinent at the 12-week follow-up. And on the x-axis is the number of tailored components. So what is pretty striking here is that there seems to be a relatively linear relationship between the number of tailored components and how successful their intervention is. So the more components that you tailor on, this would suggest the more efficacious it is. However, at some point, there's likely to be a plateau. So, with expanding effort, you have potentially expanding efficacy or effectiveness, but at some point, you're probably going to flatten out, and you might do more and more tailoring, but it's not really getting you any impact. So I don't think there's a lot of information or literature about how to hit this sweet spot here where you can do a little bit more tailoring and get a lot more impact. And that's definitely something to think about as you might be designing one of these interventions. The second issue is reach versus depth. So one of the studies that I had was another vaccination study, and it was looking at providing information on adolescent vaccines. And we had 2 ways in which we were delivering this. One was a kiosk with an iPad in it, shown here, and the other was delivering the information to a person's personal desktop through, or I guess it could be their work desktop, but their own computer at home or somewhere else, not in the clinic, through an email. So the kiosk-based intervention had a waiting room kiosk, and one of the practices that we were working with actually elected to take the iPad out of the kiosk and make it more like a roving iPad intervention that could follow people around the clinic. And because we had some troubles early on with our recruitment, we actually incentivized this type of intervention. So people received $10 for finishing the baseline survey, which is what you had to do to be able to get to look at the tailored content. This is compared to a home computer-based type of intervention, which used the exact same website and had no incentive and was delivered to people either by a postcard saying like, hey, look at this cool website, go on this web address, or by an email saying, here's this cool website, click on this link and you can get more information about how to vaccines. So before I get into the results of what we found there, I want to just point out one more thing about these web-based interventions, which is the dashboard. The dashboard is like the best thing and the worst thing that these interventions have. So what the dashboard is actually a real-time feedback of information about how many people are using your intervention and who they are. So this is from the kiosk project, and you can see along here there's dates. It spans from July of 2012 to November of 2013, and this is the number of people that logged in. So you can see that there's a lot of variability, and you can imagine when you're stretched out and you're like in this period here where there's nobody interacting, you're feeling sad. When you're at this date, you're like, woo, 12 people are looking at my intervention, this is great. So it's helpful because it can help you strategize about whether or not you need to change your recruitment strategy. The other thing that the dashboard does is provide you information about who's using your website. So on this side, this talks about enrollment. We see how many people have entered the site, which means that they touched the iPad, how many have consented, how many actually have consented and have an eligible child in the family, what proportion of those who consented started the baseline survey, what proportion of those finished the baseline survey, and what are some of the demographic characteristics of their children. And then I don't have a slide of it, but there's also a dashboard screen that shows you which web pages you went to. So you can see, oh, people looked at the home page 27 times and at the HPV vaccine page only 1 time. So getting back to our kiosk versus home computer, we found that after we made a bunch of recruitment efforts, we were able to reach about 65% of the people approached with the kiosk or roving iPad, which means that about 65% of people who were approached consented, and then a smaller proportion of those actually finished the baseline survey, but it was still relatively good. However, when we looked at the web pages that those people viewed, they only viewed 1 to 2 of our 20-some web pages, and most of the time this was the home screen or the menu screen, so not really the impact or delivery of tailored information that we wanted. In contrast, when people got the intervention delivered to their home computer, we reached a much smaller proportion, so only about 4% of people actually logged into the site, but most of those people viewed a lot more pages, so 7 to 10 pages as compared to 1 to 2. So it's not really clear which is better. I think in our particular situation, it's probably better to have depth, since we know that the other group that had a lot of reach only looked at the home page and the menu, but there may be some instances where reach is more important than depth. So it's just another thing to consider when looking at these interventions. And then the last thing, and I'd love to get some audience feedback on this particular topic, is the idea of effectiveness versus usefulness. So we all know there are thousands and thousands of apps out there that are health-related, lots and lots of websites, and although I don't have specific data on this, I'm guessing that 99.9% of them have not ever really been evaluated scientifically for either the positive or negative impacts or their effectiveness. And most of them are probably not based on health behavior theories or scientific principles. They're probably just informational websites. But, you know, that doesn't necessarily mean that they're not useful. So one of the things I'm struggling with these vaccine-related interventions is that although I have not been able to assess their effectiveness in terms of vaccine uptake yet, I know that they seem to help people's attitudes about vaccines and improve them. And people are asking me to have access to them, and I don't have a way to give it to them yet. And I'm struggling a little bit with whether or not it's actually ready for them to be used in a more public domain, or if this is something that needs to remain in the research realm until we have a better idea of what the effectiveness is and if it is effective. And then that brings up the question of even if it's not really effective in the way that I want it to be, maybe it's still useful and still needs to be in the public domain. So I don't have an answer to this, but if anybody does have an answer, I would love to hear your thoughts on that. So just to summarize, there's a large body of literature supporting the effectiveness of tailored messaging as a potential mechanism to improve compliance with a wide variety of health behaviors, although the effect size is variable and depends somewhat on the type of tailored materials and the health behavior that you're looking at. Tailored messaging interventions can really be done by anyone using free software, and there's a lot of different outputs that it can take, but there are still some unanswered questions about how to optimize the delivery of the tailored information and the content of the tailored information. So that is all I have for you today. I would be more than happy to take questions either now or by email. My contact information is above, and I live up on the 3rd floor in this building, so you can find me here and track me down if you want to do that. And that's all I have for you. Thank you so much for your attention.